Well, good morning, everyone. Please let me start mentioning how honored I am to share the stage today with Georg and to be representing the Hybrid Mind project and presenting you for the first time the empirical results of our project. So as you know, probably by now, the Hybrid Mind project is this international effort to bring together researchers from Canada, Germany, and Switzerland to investigate what is the user's experience with neurotechnologies. And today's talk will mostly try to summarize what have we learned so far from the interviews we have collected with users of intelligent neural interfaces. And just to briefly show you the outline of today's presentation, I will first start introducing what has already been done in the field of qualitative research with user experience of neurotechnologies. Then I will introduce you to our new study, so our empirical qualitative research investigation, and then I will let the stage to Georg that will introduce you instead what the results has shown us, and in terms of discussion about hybridity, revealing thoughts, altering thoughts, intelligent neurotechnologies, and to conclude, what can we summarize, what can we take from the user's experience to move forward in the neuroethics debate. So you may have already heard this a few times over the last days, but let me just remind once again the definition of a hybrid mind as defined in our project. A hybrid mind is the integration of a biological cognitive system and an artificial cognitive system. So the integration of the brain with AI-enabled neurotechnologies that are integrated and bidirectionally influencing each other and mutually adapting to each other. So what we have already discussed also over the last days that the hybridization and this mutual adaptation is not yet out in clinical practice. It's still like AI-enabled neurotechnologies are still at the nascent stage, but it is important to start discussing what are the users' experiences when using neurotechnologies for clinical applications. Because as we have seen this morning, the development of these technologies and the integration of the biological and the artificial systems is getting tighter and tighter. And as you have already seen, it is now possible, at least in the research environment, to record neural activity and in real time use this activity to inform a spinal cord stimulator that allows patients who suffer spinal cord injury to walk again, even if for a limited amount of meters, but it is a progress. And we see the potential start of use of these technologies in clinical therapy, for example. So perhaps not a technology that can support patients at home, but that may promote functional recovery. So it is important to start asking ourselves, what are attitudes and view of patients about phenomenological and ethical issues related to neurotechnologies. And we have started our work in the Hybrid Mind project with a scoping review. So we have asked ourselves, firstly, what has already been done? There are already studies investigating qualitative experience of users of clinical neurotechnology. So what has already been shown? We screened 485 studies to then include 36 in our scoping review. And what popped out immediately is that all studies were conducted in Western context. And as we have heard yesterday, the most widely applied technology is deep brain stimulation. And this is also what was reflected in our review. So we mostly found research addressing users of deep brain stimulation for Parkinson's disease. But there was already quite a nice heterogeneity of studies, because we also found non-invasive use of non-invasive technologies such as EEG, electroencephalography, and patients of psychiatric disorders. So, for example, with depression. And I would say that the main outcome of the scoping review is that even when trying to pull out together several studies using several neurotechnologies and addressing several patients, it is hard to come up with one evaluation of neurotechnologies. It is hard to say whether they have a positive impact or a negative impact, because this highly depends on the disorder. And I think the clearest example is personality change. So if we imagine that a patient has reported a change in personality, this may be seen from the patient himself as very positive when the neurotechnology is being used to address the depressive condition, depressive symptoms, while it may not be perceived as positively when the patient suffers from Parkinson's disease and is trying to suppress motor symptoms. We then decided to move forward with a new qualitative investigations and decided to run a multi-site empirical study, which has, as I said before, involved research groups in Canada, Germany, and Switzerland. We have collected more than 100 interviews in Germany, Italy, Switzerland, and Canada. And we have conducted semi-structured interviews that will be analyzed with thematic analysis and IPA, but also scales and questionnaires to have a quantitative support of the qualitative results of this investigation. And once again, the scope of this project is to explore the patient-centered views and attitudes towards phenomenological and ethical issues related to neurotechnologies. For today's presentation, we have selected a subsample of this data set. In particular, we have selected 60 interviews conducted with patients suffering from resistant depression and using TMS to treat the symptoms, and patients having Parkinson's disease and using deep brain stimulation to target the motor symptoms. So, as you may know, this is two different neurostimulating techniques. One is invasive, one is not, but both are used as a last resort for these patients. So there is no alternative treatment for their symptomatology. And so Georg will now show you the results of the thematic analysis we have started and are running so far.
Well, thank you very much, Annalisa. I'm very happy now to follow up with guiding you through some of the first empirical results to give you a glimpse of what we have been doing. As you can imagine, especially all of you who have been working with qualitative data, even taking a subset of 60 interviews, it's highly contextual, very rich data. So we decided to focus on a few items that we think connect quite well with other topics that are central to this conference, one of them being the question of hybridity, because we were, of course, interested, is this something that also users of current technology do perceive to some extent as an issue? And the simple and straightforward question is, of course, it depends. Because as you can imagine, we have two very different types of technologies in our sample. We have a non-invasive transcranial magnetic stimulation where patients go to the clinic to receive their treatment, and we have an implantable device in the case of deep brain stimulation. So there's quite different questions of how they perceive these technologies with view to their self, to their body. But still, it's interesting to see which kind of narratives come up, because often actually people were referring to popular culture themes. So for instance, in the Swiss example, we had one person saying, well, my children actually now came up with this idea that they call me Iron Man, but he himself was drawing on an experience, an embodied experience he had made previously because he had tattoos, and said, well, it's actually not that different from getting a tattoo, getting a deep brain stimulation, because it's letting a foreign body inside my own body, and he could relate this to a previous experience. Whereas on the other side, the TMS users mostly said this is actually not part of our body. It's not such a neurological drastic procedure that you have this kind of tension between man and machine, that you have this hybridization. So instead they drew on different experience they had made. So remember, all these TMS users were, pretty much all the TMS users were treated for treatment-resistant depression. And they compared it as something that's alike to the pharmaceuticals they usually had been taken previously. Now, we have heard yesterday quite a lot about neuro rights, freedom of thought, And this is also something that we see in being reflected in the quantitative data that we collected. So we also administered some standardized scales. We also developed a questionnaire specifically for our project. And you can see that, as you may expect, the deep brain stimulation users are much more likely to consider the device as a part of themselves, of their body, usually even here not of their mind, whereas with the TMS that was much less the case. Coming to neuro rights, so we heard yesterday quite a lot about mental privacy, and of course it's interesting for us to see, is this also a concern that is shared by actual users of neurotechnology? And we had specific questions to that. So are they somehow worried about this collection of data, about revealing of thoughts through this? And generally, there was relatively little worries in our sample about the collection of neural data in a clinical setting. We had one being very blunt in Canada saying, anybody who wants to read my brain data, go for it, which is probably not the best approach, but people were quite confident that at least in the clinical setting, this was okay. And also people had quite a large amount of skepticism generally with regard to what we currently can do with these kind of data, thinking that, well, just because you can read or access my data, you cannot read my mind or anything, which I think chimes also well with what Frederick was presenting earlier today. And sometimes these two topics of hybridity and of mental privacy were actually linked. So we had people saying, well, I now feel like an iPhone with a deep brain stimulator implanted, but actually that doesn't worry me. So people generally seemed to not perceive brain data as largely different from other sensitive personal data. So just said, well, we can rely on existing privacy regulations. Now, the question is, of course, we concluded our data collection in January this year, whether this was already informed by all the debate that has been going on. And in this regard, I think it's a nice follow-up also to the previous session on hype, because as you know, there's been quite popular books in the past year. There's been these developments with view to using generative AI to reconstruct fMRI images. There's also the famous example of reconstructing a brick in the wall from EEG data. So you can think about these more general scientific, but also popular developments as maybe informing patients that they could be more worried about mental privacy. So the question is whether this is actually still appropriate, that they think it's not an issue, because people were worried about privacy, but it was more about an overspill of general fears that you see in other areas of society. So people were very worried about commercial use of their personal data, giving to big technological companies or insurance companies and being potentially misused. They were worried about even also political abuse of data. And some were quite resignated, saying, well, you can't find anything about anyone anyway. If you don't live under a rock, there's nothing we can do. This all goes to stress the point that generally in our sample, we saw people very much value privacy and thought that this was important to pursue, and that actually they welcomed research on this, whether from regulators or from bioethicists, as in our example. Second brief mention, I want to go to look at what we have discussed as freedom of thought, cognitive freedom yesterday. So are people worried that somehow their thoughts can be controlled by the technology with which they're interacting? And interestingly, this was not related to freedom of thought, but people generally perceived that they had more control over their lives now that they were using these technologies, in the sense that it was brought about by their physical improvements, by their improved symptoms. So if they were very ill, if they were unwell previously and had strong motor symptoms, for instance, or were very depressed and now got better, they said, well, of course, I have more control over my life now. But there were also actually worries about being controlled from the outside. So in this regard, I think there is this real worry again, with a phone. So people extrapolated from, well, my phone can be hacked, and now people are offering me to connect my deep brain stimulator with my phone. So if the phone can be hacked, probably then also my device can be hacked. So I'm not going to touch these apps that somehow can allow me to integrate these two systems. Last but not least, we are talking a lot about, or have been talking a lot about, integration of AI into neurotechnology in these past days, and that was also central to the idea of the hybrid mind. But at least in this sample of the TMS and DBS users, this was actually not technology where AI at this stage played a huge role in the interviews, in the patients whom we interviewed. And generally, patients were quite happy if we put them a hypothetical question: would you like to be treated with something that also integrates AI, if it served to optimize a specific process, even though people had a very strong preference for still having a human physician in the loop to say, well, you need to be able to talk, to tell someone how you're responding to the changes. So even if you're setting up a closed loop system, there still is a wish to be able to access a clinic and have this human contact. Unless, because again, it's very contextual and rich data, people were generally distrustful of other humans or of medical professionals, then they said, well, maybe it's actually better if the machine does that, because it's very unscientific what we do at the moment, this kind of trial and error of testing out different settings. So actually, it's better if a machine does that, because maybe they themselves have, or expressed in this case, that they have a hard issue trusting other people. And generally, also here, again, we see that patients kind of went, at least in our sample, to stress the necessity of regulation, saying, well, I think it's important to try to contain the use of AI in this context, but that's not my job as a patient. That's on other people who are more knowledgeable about it, who have to do that. And I think that's goes to the core of what we have been trying to do with this conference. And with this, I already want to conclude just a few ideas on how to move forward. We have been talking about legal frameworks. We also think that it's important, now that AI and neuroscience are moving together, that we have a better alignment of these two discourses in neuroethics and AI ethics that have so far often moved somewhat in parallel. Some of you may have seen that Marcello Jenka and I edited a book to which many of you also actually contributed, which we had on exhibit yesterday in the back. We certainly need more cross-cultural perspectives. As Annalisa mentioned, there's a very strong, if not exclusive, focus to Western studies at the moment. And all this can maybe serve to get a better grip at user-centered design. I thank everyone who has been contributing to this large international effort, particularly my colleagues from Charité and from Canada, and you all for your attention, and I look forward to the discussion. Thanks.